Hi guys, welcome to question series. This is about cardiovascular system. A 7-year-old girl is brought to a clinic because her parents are concerned she is no longer interested in playing sports. Recently, she even walked off the field mid-game due to leg pain. She is not on any medications, her vaccinations are up to date, and her vital shows 36.7 degrees Celsius, 130 by 80 mmHg, which is high for a child. Pulse is about 80 and respiratory rate is about 60. On examination, her height is about 2 percentile and weight is at 10th percentile, indicating poor growth. You also noticed a systolic click and 2/6 systolic ejection murmur, and more importantly, her femoral pulse are diminished compared to her brachial pulse. There are also an asymmetric curve of thoracic spine suggesting scoliosis. Now pause for a second and connect the dots. High blood pressure in the child, diminished femoral pulses, murmurs and click, stature and scoliosis. This clinical picture is classic for aortic coarctation, a congenital narrowing of aorta that reduces the blood flow to the lower body and increases the pressure in the upper body. The systolic click and the murmur are just suggestive of bicuspid aortic valve, which commonly coexist with coarctation. But there are more going on here. The short stature, the scoliosis, and cardiovascular anomalies point us towards the syndromic cause, specifically Turner syndrome. Turner syndrome results from loss of an X chromosome and is commonly present with short stature due to SHOX gene deletion, left side heart defect like aortic coarctation and bicuspid aortic valve, and more importantly, gonadal dysgenesis where the ovaries are underdeveloped and fibrotic, leading to estrogen deficiency, primary amenorrhea, and infertility later in the life. So, suggestive answer. Finally, the answer is gonadal dysgenesis. Let's quickly rule out the others. Blue sclerae, seen in osteogenesis imperfecta, not coarctation. Brush-wheeled spots, associated with Down syndrome. Neurofibromas, the part of neurofibromatosis type 1, not related to this case. Skin elasticity points to Ehlers-Danlos syndrome, not Turner. Thymic hypoplasia seen in DiGeorge syndrome, which present much early and with immune deficiency. Takeaway points. Aortic coarctation in the child with short statures and scoliosis should promote evaluation for Turner syndrome. And key associated finding in Turner syndrome is gonadal dysgenesis is due to streak ovaries and lack of estrogen productions. Hope you enjoy this. Thank you.